Ensuring the well-being of both mothers and children lies at the heart of efforts to promote maternal and child health, fostering a future where every family thrives with access to quality care and support from infancy through adolescence. Navigating the delicate realm of prenatal care, understanding and addressing fetal abnormalities during pregnancy are crucial steps in safeguarding the health and development of both the unborn child and the expectant mother, ensuring a journey towards a safe and informed childbirth experience. I am Sadi Iliaga, a student nurse from Davao Oriental State University, and on this video, we will going to talk about the abnormalities of the cord, Vasa previa, and Placenta Accreta. Umbilical cord abnormality was defined as cord entrapment, knuckle, body, or shoulder cord accompanied by the evidence of cord occlusion by histopathologic exam. Knots, torsions, or strictures with histopathologic evidence of thrombi or other obstructions, and evidence of fetal hypoxia, cord prolapse, vasoprevia, or compromised fetal microcirculation. Now, let's talk about the abnormalities of the umbilical cord. First is the single umbilical artery or the SUA. Instead of the normal 2 arteries and 1 vein, there is only 1 artery and 1 vein in the umbilical cord. This condition is generally benign but may be associated with other congenital anomalies. There is also an increased risk of intrauterine growth restriction, prematurity, and mortality among neonates with SUA when compared with those with a 3-vessel cord. Obstetrical history of the mother, like parity, was identified as an important predictor of SUA. Further investigations are suggested on risk stratification of neonates in this regard. So let's learn about marginal insertion. Marginal insertion is when the umbilical cord insert at the edge of the placenta rather than in the center. So basically, this anomaly may sometimes lead to placenta insufficiency. There is a chance that the fetus may develop more slowly with this kind of insertion. Next is cord knots. Cord knots occur when the umbilical cord forms knots during fetal movements. While usually benign, tight knots may impede blood flow and cause fetal distress. And we have this one called cord length anomalies. It is the abnormalities in the length of the umbilical cord, either too short, which may cause restrictions of fetal movements or compression, potentially leading to decreased blood flow and oxygen supply to the fetus. Or it may be too long, which may lead to cord prolapse or entanglement. And this anomaly can cause vasoprevia. And cord torsion, it is a twisting of the umbilical cord, leading to potential compression of the blood vessels and reduced blood flow to the fetus. Next is umbilical vein varix. An umbilical vein varix is defined as focal dilation of the umbilical vein. Most cases of fetal umbilical vein varix are reported to be intra-abdominal. Fetal intra-abdominal umbilical vein varix or PIUVV is a rare pathology and suggests an enlargement of the umbilical vein. Management variables are the diameter of varix, presence or absence of turbulent flow, and fetal anomalies. Umbilical artery aneurysm is a very rare condition. Till date, 14 cases are reported and only 4 had good fetal outcome. Umbilical artery aneurysm is associated with high risk of fetal aneuploidy and fetal demise. Aneuploidy is the presence of 1 or more chromosomes or the absence of 1 or more chromosomes. The risk of fetal aneuploidy rises with increasing maternal age, because fetal aneuploidy can affect any pregnancy. All pregnant women should be offered screening, and a tumor of the umbilical cord may also happen. It is a very rare event that can be diagnosed prenatally by ultrasound examinations. Only 2 true tumors occur in the umbilical cord. First is the angiomas and more rarely the teratomas. So these anomalies can be detected during prenatal ultrasound examinations or observed during childbirth. Management depends on the specific anomaly and its potential impact on fetal well-being. And now, let's talk about Vasa previa. So Vasa previa, it is a rare pregnancy complication occurring in approximately 1 in every 2,500 deliveries. It happens or occur where unprotected blood vessels from the umbilical cord travel across the opening of your cervix, and it can lead to severe blood loss for your fetus if it's not carefully managed. It can be fatal to the baby when the membranes around the baby ruptures. So these blood vessels can rupture too. This can cause the baby to lose a lot of blood, and the mother may have the complications as well. So what are the causes of vasoprevia? So there are two main causes of vasoprevia. So these are the filamentous cord insertion and the bilobe, multilobe, or succensurate placenta. So in filamentous cord insertion, it happens when the umbilical cord that connects you and your fetus doesn't attach to the placenta correctly. In filamentous cord insertion, the umbilical cord inserts into the amniotic sac or attaches to the membranes outside the placenta instead. And if the blood vessel in the amniotic sac are above the cervix, then it can lead to complications during pregnancy and causing vasoprevia. Okay, so as you can see here in the picture, the cord is not attached to the placenta and the blood vessels of the cord are exposed. So when this happens, the cord may have the possibility to get into the top of the cervix or the birth canal. So when the time comes that the mother will get into labor, so it can cause bleeding, and it can cause tension and compression to the umbilical cord of the baby, which can be fatal for the mother and the baby. Okay, so for the bilobe, multilobe, or succensurate placenta, so in this case, your placenta can form two lobes, which is called a bilobe placenta. Rarely, it can form more than two lobes, which is called multilobe. Sometimes, a smaller lobe called a succensurate lobe forms. So, vasoprevia happens if the blood vessels that run between these lobes end up lying in the cervix. Vasoprevia is serious and can result in stillbirth. However, with the prenatal diagnosis, careful treatment, and a scheduled cesarean or C-section, the survival rate is 98.6%. So, what are the symptoms of vasoprevia? So, the symptoms of vasoprevia may not always be evident. Rather than relying on symptoms, your healthcare provider typically identifies vasoprevia through routine pregnancy ultrasounds. But in uncommon cases, individuals with vasoprevia might experience painless vaginal bleeding during the second or third trimester. So this bleeding may appear darker than red than usual, indicating fetal blood rather than maternal blood. So if you observe any bleeding during your pregnancy, whether accompanied by pain or not, it is very crucial to seek immediate medical attention. And also, fetal bradycardia is also observed. So how can we fix it? How can we fix vasoprevia? So unfortunately, you can't fix vasoprevia. But with a good planning, we can improve your chances of successful delivery and a healthy baby. So seek advices from your healthcare provider about best time to schedule your C-section so that the delivery is safe for you and your fetus. Okay, so how can we prevent it? How can we reduce the risk of vasoprevia? Unfortunately, you can't reduce your risk of vasoprevia, but you can reduce your risk of experiencing the most serious complications by getting regular prenatal checkups. Now let's talk about placenta accreta. So placenta accreta is a severe pregnancy complication where the placenta implants or grow too deeply into the uterine wall. But normally, the placenta detaches from the uterine wall following childbirth. However, in cases of placenta accreta, either a portion or the entire placenta remains firmly attached. This can cause severe blood loss after delivery. It's also possible for the placenta to invade the muscles of the uterus, or placenta accreta, or grow through the uterine wall. There is no preventive measures for placenta accreta. Women at highest risk of developing accreta are those who have a history of cesarean delivery or C-section and the presence of the placenta previa. So how does C-section causes placenta accreta? Typically, due to scarring after a C-section or other uterine surgery. In a systematic review, the incidence of placenta accreta spectrum rose from 0.3% among women with one prior cesarean delivery to 6.74% among those with 5 or more cesarean deliveries. Placenta accreta is more common among women older than 35 years old. Placenta previa, it is an independent risk factor for the accreta due to pressure inserted to the cervix. It causes scars to the endometrium and myometrium lining of the uterus. Scar tissue on the uterus is one of the most significant risk factors for placenta accreta. Placenta accreta often causes no signs or symptoms during pregnancy, but although vaginal bleeding during the third trimester might occur, occasionally, placenta accreta is detected during a routine ultrasound. Ultrasound serves as the main diagnostic method for placenta accreta, with the majority of cases being detected during the second and third trimesters of pregnancy. However, it is crucial to acknowledge that ultrasound is not infallible. Even in the absence of ultrasound evidence, the risk of placenta accreta increases with the number of C-sections or cesarean or other uterine surgeries you had. Other is placenta position. If the placenta partially or totally covers your cervix or the placenta previa or sits in the lower portion of your uterus, you're at increased risk of placenta accreta. Next is maternal age. Placenta accreta is more common in women older than 35 years old. Other risk is previous childbirth. The risk of placenta accreta increases as your number of pregnancies increases. So, for the complications of placenta accreta is heavy vaginal bleeding. Placenta accreta presents a significant risk of severe postpartum vaginal bleeding, known as hemorrhage. This bleeding can lead to a life-threatening condition called disseminated intravascular coagulopathy, impaired lung function resulting in adult respiratory distress syndrome, and cause kidney failure. Treatment typically involves a blood transfusion to address the blood loss. Next is vaginal delivery. Vaginal delivery isn't always possible, even in the cases of vaginal birth. Women might need a specialized procedure to extract the placenta and manage hemorrhaging. If placenta accreta is identified prior to labor, healthcare providers may advise a cesarean section or C-section. Next is premature birth. Placenta accreta might cause labor to begin early. If an early heavy bleeding from previa makes the mother unstable, then the baby can become unstable as well as the mother. The accreta itself is not directly harmful to the baby. However, it causes preterm birth. This will usually occur between 34 and 37 weeks gestation or 3 to 6 weeks early, depending on the severity of the accreta. Babies born at these gestational ages often require admissions to a newborn intensive care unit or ICU. One complication may happen is hysterectomy, or the surgical removal of the uterus. Hysterectomy may be required after delivery to remove placenta and end the blood loss. So, does a mother with placenta accreta need hysterectomy? Unfortunately, most women with accreta lost their uterus due to the life-threatening potential of this condition. Most cases of accreta require hysterectomy. In rare and individualized cases, conservative and expectant management may be considered. Conservative management is when a portion of the placenta is removed. Expectant management is when the placenta is left inside the uterus. So it is very important that we healthcare providers encourages every pregnant mother to attend or follow up their prenatal checkups. Prenatal checkups are vital for monitoring the health of both the mother and the developing fetus, providing early detection and address any potential complications early on, ensuring optimal prenatal care and promoting a safe and healthy pregnancy for both the mother and the baby. And that's all for this discussion, and I hope that you've learned a lot from this video. And again, I am Sally Iliaga, a student of Bachelor of Science in Nursing at Davao Oriental State University. Thank you for watching. God bless you all. Godspeed.